everyone. It's great to be here. My name is Michelle Lynn, and I am a health services researcher here at Mount Sinai, or sorry, not here. I'm from Mount Sinai in New York City, ANO times 2.
I'm Maggie Samuels-Kalo. I'm also a health services researcher from MGH in Boston.
I'm Elizabeth Schoenfeld, a researcher from UMass Bay State.
And we're going to be presenting the findings from last year's consensus conference on social emergency medicine. I certainly think there's some overlap that will be helpful as you set your research agenda today. We have no financial disclosures. And I do want to emphasize that this is a group effort, and I'm presenting a lot of work that was done by a lot of people, and some of it on their behalf. So just really want to emphasize how big of an undertaking a consensus conference is. So, I think as many of you know, I think the concept of social medicine has been around for a very long time, but probably in the last decade or so, it's really been formalized within emergency medicine. In 2017, the Robert Wood Johnson Foundation and the Levitt Center co-hosted a summit on inventing social emergency medicine, which we feel like was applying terminology for a paradigm that had long been in place because of the populations that we care for and the mission that we serve. And since then, there's really been an explosion of interest in social emergency medicine with over 10 fellowships across the country, and I think an increasing recognition that what we do for patients expands outside of the four walls of the emergency department. With that in mind, we set our social emergency medicine conference a little bit differently than prior conferences. We really wanted to focus not just on the research priorities, but we also wanted to create a forum for enhancing collaboration and future networks to cultivate both research and advocacy and educational projects focused on a lot of these problems. So the first 3 sessions were more akin to sort of what had been the morning sessions, and those were around setting research priorities for screening in the emergency department for social risk and social determinants of health, around structural competency, which we'll define later, and then also around structural racism and anti-racism. And the afternoon sessions were really intended to feature people who had been actively doing projects, both in research and advocacy, but wanted to take learnings from, I think, best practices and barriers that people had encountered in their own work and be able to share that. Because of COVID, we had to rebuild our plan for an in-person meeting, and instead we held 3 virtual sessions. So on the first day we had our keynote, and then we presented the literature review, and then talked about the draft priorities with a survey in between. On the second day, these priorities were represented. We had a second keynote, and then on the third day, there was actually no consensus making. It was focused on the projects in progress and on the third keynote. So I'm going to start with the research priorities related to screening for emergency department social risk and social needs. Just a note on terminology, I think the words social determinants of health and social risk and social need are frequently floating around the literature. I think we think of social determinants of health as things that can both adversely and positively impact someone's health outcomes. So for example, race, right? White race can often be a positive social determinant, and black race, on the other hand, can often be a negative social determinant. And then we refer to social risks as things that people screen in for, whether or not they actually identify a need for those services, and then social needs as something that people may feel like they could benefit from, but may or may not actually screen positive for. And Maggie here has done some incredible work on the need to distinguish between those. And we did find that there was a lack of standardization in the terminology that was being used. So that was a really big barrier to coming up with a research agenda, and that there were tons and tons of observational studies, but very few interventional studies, and very few that measured outcomes that were patient-centered. So that continues to be a limitation to programs that screen for social risk in the emergency department setting. And I can move on to the research priorities. So, this is a really massive field. So this group had to break up into 3 subgroups, with the first one focused on instruments that are used for screening in the ED setting, and the second one focused on how to implement screening in the very busy ED setting, and then the third one focused on interventions to mitigate social risk. And this is a very, very brief summary, but just to give you a sense of some of the areas where we felt the need to prioritize future research. A lot of the tools that we use are developed in other settings or often not validated at all, and we know that the emergency department population may have special needs with respect to health literacy. So we felt there was a need to, rigorously validate the tools in the ED setting. We talked a lot about what social risks and needs are best suited for screening in the ED setting. Something like housing is something that we see very, very frequently, but it's not so helpful to hand someone a piece of paper and say, here, go figure this out. And so there are certain things that we feel like we need more research on how to best reach patients who could benefit, and what the ED is optimally structured to provide. We talked about the need for universal or targeted screening. I think that there's actually a fair amount of evidence coming out about this, less so in the ED, but increasingly so, with the thought that, it may be appropriate for some patients and patients may benefit, but, if you're screening universally and you, for example, may not have the resources to refer folks to those identified needs, there are certainly ethical implications to that. And then we talked about the implementation of screening in the ED environment. One of the key priorities was having EDs engaged with local community resources. I don't think screening is something that, you just have a one-size-fits-all program that works across the country. It really depends on what types of partnerships you can establish with the CBOs in your community. And then we talked a lot about how to optimize the workflow of screening, who delivers it, at what point in the ED course or visit, what types of technology do we use that are not accessible, and who is best, trained to do the screening and or referral. And then the last section was on interventions to mitigate social risk. So I think the biggest barrier is a lack of well-established outcomes. I think linkage has certainly been used as one, but uptake of services and reduction in the social risk would be optimal. So we don't really have great patient-centered outcomes for that. And then in general, how to improve linkage to the community and to other resources.
The second group really focused on thinking about issues of structure and structural competency. When we think about structure in this context, we're talking about the ways in which life and activities are organized and ordered and constrained, and in particular around structural vulnerability, so the physical and emotional suffering that's imposed in patterned ways because of class-based economic exploitation, racialized and other forms of discrimination. And we want to think about structural competency really rather than cultural competency, which is subject to bias and stereotyping. We would move to this concept of structural competency as the trained ability for health professionals to recognize and respond to signs and symptoms of individual illness as the downstream effects of broad historical, social, political, and economic structures, which I think is important for the work that we did in the social emergency medicine consensus conference, but also important in the work that we're going to do today. And we divided our thinking of structural competency into 2 groups, one that focused on education and one that focused on research. Both groups did a scoping review and a consensus conference process. We found 291 articles that touched on structural competency, and there were 51 that were relevant for the education group. Within that education subgroup, they really consistently conceptualized structural competency as an interdisciplinary framework. This isn't something that's just relevant for medicine or just relevant for emergency medicine. But there was no consensus on how to measure the effects of structural competency on either learners or on patients. And importantly, no studies examined the structural constraints of learners. So here we're starting to think about what are the questions, what are the research agendas, what are the areas where we haven't yet started to think about the answers. And so our findings were that we really need this training for structurally competent physicians via a national structural competency curricula. This isn't something that a single emergency medicine residency can solve by themselves. It's going to have to be something that we come together and do together that focuses on the standardized core competency proficiencies. And we need to assess the impact of those curricula both on patient outcomes and on the learners themselves. This is just a picture of the framework that's coming out in academic emergency medicine education and training, and I encourage you to take a look at this paper if you're interested in learning more about the educational side of the structural competency work. Just to summarize briefly the research side of that paper, there were 123 articles that were relevant talking about structural competency in research. These articles were in some ways a little bit less useful. They acknowledged or described structures, but they had a really wide variety of methodological approaches, and they didn't really provide a framework for how researchers should handle these issues of structure within their work. And so the consensus conference process focused on trying to create framework and recommendations for researchers in emergency medicine to try and reframe these drivers of inequity away from individual factors and to focus on structural factors. And they came up with a framework that really walks researchers through the research phase, trying to think about what are the issues that are relevant to structure in each phase, and what are the checklist of recommended actions, both through defining the research questions in the study design, the data collection and storage, analysis, interpretation, dissemination, and policy change. And I'll take you through just one of those aspects. Even something as simple as data collection and storage. We need to think about methods that both recognize and mitigate structural forces. So who's going to be collecting that data? Will the study populations feel comfortable with the people who are collecting that data? How is that data being collected? Is it written or electronic? In what language? And is that the ideal method for data collection? That may necessitate conversations with your IRB, with your institution around data storage, with your community partners. How is that data going to be stored? And will the appropriate individuals have access to that data? Is that data going to be stored at a community site? Is that data going to be stored at a hospital site? How are you going to share that data with your community partners if relevant? So this is the research framework for trying to think about how we incorporate these issues of structural competency into the work that we do as emergency medicine researchers.
That was a lot. This is a lot in just a few minutes. So the third group was looking at, I think we sort of called it racism and anti-racism in emergency medicine, which is obviously overlaps with this conference and is a huge category that we could put a lot in or we could focus. And I think that is really a big challenge and was a big undertaking. And I'm hopeful that there is some overlap in all of you who were involved last year. And I know that there certainly is some. So in our review, I think that we saw a lot. Did this just advance on its own? Anyway, we did a gigantic review and tried to include everything that we could that would sort of make sense. But at the same time, obviously, there is a lot of literature within emergency medicine and outside of emergency medicine that is either directly relevant or sort of tangentially relevant. And a lot of things were very clear. There's been a lot of research in different areas, particularly different clinical areas, on disparities. And we know that there are substantial disparities by race in many, many different clinical areas that we looked at. And that's pretty clear. But as our second point makes, very few of it calls out racism. It just says there's racial disparities. And a lot of these studies are observational and they don't get into any causality. And a lot of them don't actually even make attempts in their discussion to discuss causality. And I think that papers are getting better about that. So very, very little interventional work was out there. And I think that does give us things to talk about today in terms of moving forward, is that we have a lot of observational stuff and we don't have a lot of interventional stuff. So it's time to do something about what we know is already out there. So a lot of gaps, particularly in what we're doing and how we're going to intervene. And so then we went through a lot of different research priorities, and I'm not going to go through necessarily all of them. What is the best way to approach this? And we can think of this at the clinical level in clinical scenarios, and we can think about it in terms of identifying racial and ethnic data properly, because we know that patients are not always identified properly in our big data sets. And so there was a lot of individual little areas that we talked about and we went through research priorities. So I'm not necessarily going to go through all of those, but a lot of different questions came up that I'm really looking forward to this group having some time to break apart and getting into even more details. talking about putting it all together with some of the other things that we've talked about, and access to care and unconscious bias. So we did group things into some of the major areas that made sense for us to look at as an area that is obviously can be to be teased apart. Obviously, access to care is a massive issue, and it affects race, and race affects it, and it all goes together. And then unconscious bias, totally, I don't want to say separate, but a totally different area for us to focus on and for us to make research priorities within that area as well. And we'll go through a few more of those. Operations, what are we doing within the world of operations to make sure that our systems work properly, which we know my ED is currently boarding a small hospital. According to our WhatsApp feed, there are 71 patients boarding in my ED right now, which it's like, who does that affect, right? That affects the people who came in through the ED and needed the most care. It doesn't affect the people who are there for elective surgery. How does that, what are the ramifications of that? But the big question for us is, how do we fix it? And how do we fix it in a way that addresses equity? Pain and analgesia is a place where all of us are aware of the research and the disparities. So what are we doing about it? What are the interventions that work? Do we have interventions that work? Do we need to implement them? Are we at the basic level where we're working on interventions that work, or are we at a place where it's time to work on implementing the things that we know do work? And then you can go through each of the conditions that we see, and there's a good amount of research on many of them. Where are we failing in asthma? Because we are, particularly with kids who are living in cities. Where are we failing with stroke? I mean, things like stroke and MI have a lot of timestamps, and those timestamps and those protocols allow us to see where the bias creeps in. And so, a lot of these things really give us clear-cut things moving forward. And I think that the other thing that they highlight is that whatever your area of interest is, there's health equity needs to be baked into that, and it needs to be addressed. You're doing a study, I do kidney stones. How does that work? How do we make sure that my kidney stone research has a health equity lens on it? As I said, we sort of went through a lot of different areas, so I'm not going to get into necessarily all of these. And then you want to talk about this?
Yeah, and then I'm just going to summarize by talking about the projects in progress. So, these were, as I mentioned, not research priorities, but just areas where people were actively doing work. And we invited them to present their projects, and we had 2 simultaneous sessions. And this is just a smattering of the types of presentations that folks gave during those sessions. So just wanted to acknowledge that one of the key goals was to establish these collaboration networks that we really hope will continue, and generate more and more research that will hopefully fix the inequities that we all know are so pervasive in our specialty. So with that, we'll end, and we'll take any questions if there's time.